So good evening. This topic is to emphasize on certain concepts which actually are associated with the word critical. So this topic is critical matters in periodontics. Now, what are the terms that is associated with the term critical? We have the critical zones of periodontal surgery. We have critical probing depth. We have critical appraisal, and we have critical analysis guide. This critical analysis guide is somewhat associated with critical appraisal, both of which is comes with the research side of the periodontal medicine or research side of periodontics. Now, first one is the critical zone in periodontal disease or critical zones in periodontal surgery. Now, criteria for selection of one of the different surgical techniques for pocket therapy are based on the clinical findings of these zones. That is, whether we are selecting gingivectomy or whether we are going to do a flap surgery or apically displaced flap surgery, whether we are going to do a bone graft, which it is all determined by these zones in periodontal surgery. So, which are these zones? We have the first zone is the soft tissue wall or either it is known as the pocket wall of the periodontal pocket. The second zone is the true root surface zone. The root surface, that is a tooth side of the pocket, is known as the root surface wall. Now the third zone is actually the bone, alveolar bone, the defects or the corrections that we have to do in the alveolar bone. That is the zone 3. And the zone 4 is the attached gingiva, the corrections that we have to do in the attached gingiva. So it is basically these 4 zones that determines what type of procedures that we have to do. What the planning of the whole periodontal surgery depends upon these 4 zones. Now we'll emphasize on which are the zones and what all things we have to look on, and what surgical procedures that we are going to do for these zones. Now the first one was the soft tissue pocket wall. Now a clinician should determine the morphological features, the thickness, the topography of the soft tissue pocket wall, and the persistence of inflammatory changes in the wall. So what all things we do? We very well know that after phase 1 therapy, we do a periodontal charting, and we get to know what are the pocket ranges, pocket depth ranges, and we will determine whether it is a gingival pocket or true pocket. If it is a gingival pocket, we will go for a gingivectomy. If it is a true pocket, and we do the periodontal probing, and depending upon the pocket depth and also the other features like attached gingiva, and whether we have to do any other corrections like bone grafting, we will modify the flap according to it, and making sure that whether we are doing a pocket elimination or pocket reduction therapy. Pocket elimination will be mostly preferred, because by which we will get to gain a normal healing. Now the second zone is the tooth surface wall. Tooth surface wall means it is actually the root surface. The root surface, we very well know that the local factors is the cause for the main cause for the periodontal disease. So this step is very important, for which we do first at phase 1 therapy. By phase 1 therapy, we eliminate the supragingival calculus and all. Now, we identify the presence of the deposits and alterations on the cemental surface. By how we can do the alterations? We can do the alterations by root planing. So by the root planing, you will get to we will get a smooth glassy root surface, so by which there is decrease in the local factor deposition, and also it enhances the soft tissue wall attachment that we get after soft tissue wall correction. Now it also it is determined by the accessibility of the root surface. So by scaling, merely a scaling, we may not get the proper access to the root surface. So for better access for the root surface, we may require a periodontal flap surgery, for which we get to treat a deeper pocket depth area. Now, after phase 1 therapy, that is by after proper scaling, the root surface we examine, and if the bone loss is much so, we may require a hemisection or radisection, or even in situations we may require a extraction. So it all depends upon the phase 1 therapy and how well the tissue has responded to the phase 1 therapy. So for this tooth surface wall treatment, we very well require the management of non-surgical and surgical management. And another point in which the root surface wall management, one concept is of that root conditioning, that is root biomodification. What we do in root biomodification, we actually open up the walls of the dentinal walls so that the collagen fibers that is seen in the blood clot will get a bonding with the dentinal wall. So it enhances the healing. That is, it enhances the healing by a connective tissue binding rather than a epithelial binding that is occurring. That is a long junction epithelium, which we assume to be having a weaker healing than the connective tissue healing. Okay, so that was about the root surface wall, that is a zone 2. Now, which is a third zone, that is the underlying bone. Now we have attended what we have managed the soft tissue wall area, the root surface. Now what we have, the underlying bone. Even though we have done a proper scaling and root planing and soft tissue wall correction, if the bone correction is not complete, the whole thing can relapse. Ideally, we have to mimic what was natural or what was normal for that area. So according to that area, we have to modify the bone also. So the management of bone is very much important, as it very well is a key factor for the success for the periodontal treatment. Now, how will we assess that? We should establish the shape and the height of the alveolar bone next to the pocket wall through what are the methods by which we can assume what can be the shape or height of the alveolar bone before the reflection of the flap is by clinical probing and radiographic methods. Clinical probing, to aid the clinical probing, we have the transgingival sounding, which will helps for determining the bone height, and if there is any intra-bony defects, we can also access that, and also by the radiographic methods. Now, through which we can assess whether somewhat we can assess the bony craters, the longitudinal or the horizontal or angular bone loss by confirming it with the radiographs. Now, what are the methods by which we can correct the underlying bone? If it is a 3-wall defect, if it is a narrow 3-wall defect, again we can manage it with bone graft or in some other regenerative methods like PRF or some other aids. Now, if it is a crater or a horizontal bone defect, or and in somewhat a wider angular bone loss, we have to manage it by resective surgical procedures. So in this type, we have the reconstructive flap surgery procedures and also the resective procedures. Okay, so next is by the management. Next zone is the attached gingiva. So the clinician should consider the presence or absence of an adequate band of attached gingiva. Now, what are the methods by which we can actually diagnose the attached gingiva? That is by the roll test, by the lip pull test, and by the dice. We have the Schilling die test by which we can actually see which is the area of attached gingiva, and if there is inadequate attached gingiva, we have plastic surgical procedures and also certain flap surgical procedures with which we can gain attached gingiva. Okay, so by merely clinical examination, we can also assess the adequacy of attached gingiva. If that is, if there is a high frenum attachment, if there is a marked gingival recession, or if there is a deep pocket that reach to the level of the mucogingival junction, that means that region is having inadequate attached gingiva. So whether we have done a flap surgery, whether we have done a bone contouring, that may not be enough. We have to address the attached gingiva too, because the mere presence of even 0.5 mm of attached gingiva is seen to be making the tissues healthy. So attached gingiva is a very must for the periodontal tissues. So when we tell you should require periodontal ligament, we should require cementum, you should require bone, like that the gingiva, and that to attach gingiva is important for the survival of the tooth. Okay, so these are the critical zones in periodontal surgery. Now, another common term that we hear is the critical probing depth. Okay, so what is critical probing depth? This indicates the probing pocket depth below which the clinical attachment would be lost as a result of respective treatment procedure, and above which it would result in the clinical gain of attachment. Okay, so it is the probing depth, probing pocket depth, which value, if we do a treatment above that value, there is a gain in the attachment, clinical attachment, and below that they tell that if you actually do the treatment, if you do a surgical treatment, there is a loss of attachment. Now, this helps to know whether or when to treat non-surgically and when to add the surgical interventions to obtain the best therapeutic result. So, this is the factor that is determining whether we have to do a non-surgical or whether we have to do a surgical treatment. So, according to Linde et al. In 1982, they have mentioned the critical probing depth as 2.9 mm for a non-surgical treatment. So when we do a probing pocket marking, and if we found out that there is a 2.9 mm, that means that site, we know very well know that the normal probing depth is 2 to 3 mm. So we have, in this case, you have found a critical probing depth of 2.9, means that is the almost the higher range end of the normal pocket depth. So when it is at the range of 2.9, that means that region is assumed to be good for non-surgical. So if we attempt a surgical treatment at that site, the authors claim that there is a chance for loss of attachment rather than the gain of clinical attachment. Now, there is also, the same authors have told that the critical probing depth of 4.2 mm is considered to be a value for the surgical treatment. So above which they claim that surgical treatments like modified Whitman flap can be done. At that time, modified Whitman flap was the most commonest flap that was being done. So they claim that modified Whitman flap, if done for this cases with 4.2 mm and more, there is a gain in the attachment level. And if it is done below these levels, they claim that there can be a loss of attachment. So this is a concept of the critical probing depth. Now, recently, Haynes, Mailed, and Lang et al. Have mentioned the critical probing depth, that is 5.4 mm. 5.4 mm. So above this level, it is very much beneficial if we do a surgical treatment. So for rounding it about, and pocket depth which is above 5 mm is considered to be a definite indication for surgical treatment. Okay, below which there are options of non-surgical treatment and some other surgical treatment like gingivectomy or something. So for 5.9, 5.4, if it is a true pocket, it is better to do a surgical treatment. Now, the main controversies of this measurement or main values of critical probing depth is that whether this marking is standardized, whether if they say we do it is like 5 mm, whether it is standardized to be 5 mm. There can be errors that can occur, and also whether it is a gingival, true periodontal pocket, we cannot assume. We arbitrarily we assume the CEJ. So there can be errors for this critical probing depth. But as per literature, there are 3 critical probing depth. That is a 2.9, which will go for a non-surgical, 4.2, which goes for a minor surgical procedures like modified Whitman, and a 5.4, which definitely indicates for a surgical periodontal treatment. Okay, so this is a graphical representation in which they have done, they have formulated how they have found that 5.4 mm of critical probing depth. That is the first around the 3 marking that we can see that it is 2.9, that is the non-surgical. Now next is the 4.2, in which we do the modified Whitman. So they have drawn a tangential line and they have arbitrarily found a value of 5.4, which they claim to be of a surgical treatment critical pocket depth of 5.4. So it is again a concept, but we will have to know the authors who have mentioned it and the year also, and we have to know what is the significance of critical probing depth. And this is mainly focusing on the non-supportive periodontal treatment side also. Now the third one is the critical appraisal. Now this comes to the research side. So we have decided to do a study. We have done a study by say for randomized control study, or we have just collected some data, previous data from the primary or secondary sources. We have got some evidence. Now we should know that these evidence that we have got is useful, or what the literature matter is useful for our study. So how will we assess that these data are useful? That is what is critical appraisal. Critically, we are evaluating that data that we have procured. So when reading a scientific investigation, the dental professional should keep in mind the questions like, what are the results? Are the results that we have just got valid? Are the findings relevant to my population? So a study that is done for a Caucasian cannot be much useful for our population. So that has to be also assessed. So the critical evaluation or critical ability to assess a study for clarity, validity, and generalizability is the importance of critical appraisal. Okay, so now how can we critically appraise whether this study is valid or not? So that there comes the significance of critical analysis guides. So through these guides, we can assess that the study that we have looked, or the meta-analysis studies that we are going through is valid. In lot of studies, we may see that the researchers have gone through some 1,000 articles and they have scrutinized to say 10 articles. So how they are scrutinizing to 10 articles? That is through these critical analysis guides. Okay, so these are actually international evidence-based groups in which there are a lot of appraisal forms and checklists that guide the user through a structured series of yes or no questions. So we just determine what all things we have to look for that study, and rather than going in depth, you just have to tell whether yes or no. So that will scrutinize your studies that is required. Now, which are the common guides, analysis guides that we follow? That is, one is consort statement, another one is quorum, and another one is CASP. Consort is Consolidated Standards of Reporting Trials. So that is the full form of consort. Now, this actually helps to improve the reporting and review of randomized control studies. So when we are evaluating a randomized control study, these consort statements are of useful. Now, there is another guide that is known as quorum, that is quality of reporting of meta-analysis. So meta-analysis means it is systemic review, but of a statistical significance. So this actually improves the reporting and review of, again, randomized control studies itself, but a meta-analysis study. Now, the third one is CAS. What is the full form? It is Critical Appraisal Skills Program. All these have this yes or no questions by which we can assume we will get to know the study that we are going through is of a good of a standard value that we are looking for. So this again helps for the randomized control studies, for systematic reviews, and all other types of studies. So in general, we can use the CAP studies for all, and randomized control studies, you have the concert statement and the quorum statement. So this is about the critical analysis guide. So these are the 4 critical matters in periodontics. The first one was the critical zones of periodontal surgery. Second one was critical probing depth. What is critical probing depth? And what are the values of critical probing depth? And third one is what is critical appraisal. So when we do a study, how will we know whether the study is of validity? Then the guides with which we do a critical appraisal is the critical analysis guide. So that is the another critical word that is coming around. So these are the 4 critical points that is what associated with our field. Okay, that's it.